This presentation will discuss cerebral palsy. The information in this presentation was compiled and organized by the 6 UTHSC DPT students listed below. Cerebral palsy, commonly known as CP, is a group of disorders that affects a person's ability to move and maintain balance and posture. CP is incurable, non-progressive, permanent, non-contagious, and non-life-threatening. There are several different types of CP. The different types of CP are determined by location and extent and type of abnormality. Spastic is the most common type of CP. The other types include dyskinetic, ataxic, and a mixture. The risk factors for CP can vary depending whether the CP is congenital or acquired. Congenital CP risk factors include low birth weight, premature birth, multiple births, injections during pregnancy, assisted reproductive technology and fertility treatments, jaundice, medical conditions of the mother, and birth and labor complications. Acquired CP risk factors can include infancy, preterm or low birth weight, brain infections, or injury. CP affects the part of the brain that specifically controls motor function. Therefore, the systems involved are the central nervous system and the muscular system. Signs and symptoms of CP can vary greatly from type of CP in individuals. They can be presented at varying times, but most common are seen in infancy and early childhood. Proper muscle tone allows normal movements of the limbs and torso of the child. When variations in muscle tone occur, the child may have problems with things such as sitting, standing, maintaining posture, or even walking. Signs that are often seen with muscle tone include hypertonia, which is increased muscle tone or tension, which can lead to stiff or rigid limbs. Hypertonia, which is decreased muscle tone. It can lead to relaxed or floppy limbs. Spasticity and rigidity. Signs can also be seen with altered movement and coordination. Such signs include asetosis, or a writhing movement, ataxia, which is abnormal or uncoordinated movements, muscle spasms, tremors, and they may also have difficulty walking and with fine motor control. Balance problems can also exist, which can lead to difficulty sitting or swaying or unstable movements. One example of this movement is a spastic or scissor gait pattern that is often seen in people with CP. Oral motor function may also be affected. Oral function may be affected through verbal apraxia, oral apraxia, or dysarthria. Apraxia is a neurological condition that affects the ability of the individual to transmit the signal to muscles to make the proper sequence of motions with oral muscles. With verbal apraxia, the individual may have trouble producing the movements needed to clearly articulate words. Oral apraxia deals more with the inability of the oral muscles to make or produce non-speaking motions, and such an example would be licking the lips. Dysarthria is a speech impairment problem similar to apraxia, but dysarthria can fall into three categories of either spastic, flaccid, or ataxic. Drooling may also be a sign seen with CP due to improper coordination of the muscles of the mouth. Additional abnormal reflexes may be seen in babies. These reflexes can include a palmar grasp reflex past 6 months of age, a placing reflex past 5 months of age, a startle reflex past 6 months, and a spinal gallant reflex past 9 months. CP is the most common motor childhood disability. 2 to 3 out of 1,000 babies born in the U.S. will have CP. Many times it is difficult to make prognosis before the age of 2. With mild forms of CP, a normal life expectancy can be seen. Those with severe CP have associated problems such as mental retardation or feeding difficulty or seizures. Differential diagnoses can be genetic, as in congenital defects or muscular dystrophy, metabolic disorders, nerve lesions, or tumors in the brain or spinal cord. The exact cause of CP may be unknown. It most commonly occurs before birth, which means the brain damage happens during fetal development. This damage can be due to the birthing process or can occur after birth. Management is different for every patient, but there are 4 common factors taken into account when deciding appropriate treatment. These include the type of CP, location of the movement impairments, level of the disability, and whether comorbidities exist. Listed on the bottom of this slide is a list of different treatments that are used depending on the presentation of the factors. Physical therapy is usually the first step of treatment and is started as soon as possible. The goals are to improve independent motor function, strengthen and encourage growth of new muscles, improve ability to move all body parts, and prevent joints from becoming tight or contracted. This is done by increasing strength, mobility, posture, balance, flexibility through strength training, stretches, and muscle relaxation. The most common treated issues are scoliosis, shortened Achilles, and other contractures. This is done partially through the use of orthotics and other assistive devices. Pharmacologic interventions are used to help control symptoms, complications, and prevent secondary conditions. The most commonly prescribed are antispasmodics, which relax muscles, anticonvulsants, which prevent or control seizures, and anticholinergics, which limit uncontrollable movements and drooling, and sometimes stool softeners or laxatives. There is a debate between doctors as to whether or not the benefits of medicine outweigh the risk for the children. An example of this would be antispasmodics that are prescribed to relieve restrictive movement but can have the side effect of drowsiness. Sometimes medical management includes surgery if it is right for the child, but it is mainly used for spastic CP to relieve restrictive movements. Thank you for watching our presentation on cerebral palsy.